Welcome to today's presentation brought to you by Compliant Coding Systems Coding Academy. Today's presentation is Introduction to Anesthesia Coding. My name is Michelle Corbish and I will be your presenter today. CPT disclaimer. CPT copyright 2015 American Medical Association. All rights reserved. The AMA does not directly or indirectly practice medicine or dispense medical services. The AMA assumes no liability for data contained or not contained herein. Fee schedules, relative value units, conversion factors, and/or related components are not assigned by the AMA and are not part of CPT. CPT is a registered trademark of the American Medical Association. Course competencies we'll be going over today: types of anesthesia services, authorized providers, anesthesia procedure codes, anesthesia service modifiers, key definitions, required documentation, key rules of coding services, qualifying circumstances, time reporting, important payer-specific coding circumstances, and global anesthesia services. Anesthesia, when broken down using the slash technique for analyzing medical terminology, is an, which means no, not, or without, anesthesia, which means sensitivity or feeling. Therefore, anesthesia is the practice of suppressing feeling or sensitivity in medicine. This can be accomplished in various ways and to differing levels of suppression. Terminology. Qualified non-physician anesthetist is either a registered nurse who is licensed by the state in which the nurse practices, who is currently certified by the Council on Certification of Nurse Anesthetists or the Council of Recertification of Nurse Anesthetists, or they could have graduated within the past 18 months from a nurse anesthesia program that meets the standards of the Council of Accreditation of Nurse Anesthesia Educational Programs and is awaiting initial certification. And we also have anesthesiologists. They are permitted by state law to administer anesthesia and who has successfully completed a 6-year program for AAs where 2 years consist of specialized academic and clinical training in anesthesia. Medicare provides payment to qualified physician anesthetists and AAs. Qualified non-physician anesthetists and anesthesiologists may bill directly for their services or have payment made to an employer or entity under which they have a contract. Examples of other entities include hospital, physician, group practice, or ambulatory surgical center. The types of anesthesia procedures. There are different levels of anesthesia complexity. By looking at this hierarchy shown on the slide, we can tell that general anesthesia is at the top of the pyramid. This indicates the service with the highest level of complexity. Next, we have regional anesthesia, followed by moderate or conscious sedation, and at the lowest part of the hierarchy is local or topical anesthetic. Let's begin at the bottom of the hierarchy and work our way up the pyramid. The anesthesia service with the lowest amount of complexity is local or topical anesthesia. Local anesthesia. According to guidelines and CPT code descriptions, the use of local anesthesia is included in the reimbursement for procedures utilizing local anesthesia. Typical circumstances for local anesthesia would include wound repairs, incision, excision, destruction of integumentary system lesions, incision and drainage of abscesses, and similar procedures that only require pain control in a localized area and typically superficially, or topical infiltration. An example would be if a patient was seen by a dermatologist for a suspicious lesion and the dermatologist decided to perform a biopsy. They may use a topical anesthetic to numb the skin prior to performing the biopsy. Another example would be if a patient came in with a laceration. Sutures may be necessary to repair the wound. The physician may decide to use a local anesthetic to numb the area prior to repairing the laceration. These are just a few examples of the way topical or local anesthetic could be used. As we move up the hierarchy from local and topical anesthesia, we come across moderate or conscious sedation. Moderate or conscious sedation. This is defined by the American Society of Anesthesiologists and CPT as a drug-induced depression of consciousness where the patient remains able to respond appropriately to verbal commands. They may require tactile stimulation. No vital system support, such as airway and respiration of cardiovascular, is required, and this does provide a deeper, broader, and more significant pain control efficacy than local or regional anesthesia services. These services are often separately billable unless otherwise indicated in CPT code descriptions, section instructions, or payer policy. Coding guidelines. A bullseye, as shown here, indicates a procedure where moderate sedation is included in the procedure. Medicare allows separate reporting for moderate conscious sedation services, CPT codes 99143 to 99145, when provided by the same physician performing a medical or surgical procedure, except for those procedures listed in Appendix G of the CPT manual. CPT codes describing anesthesia services 00100 to 01999 or services that are bundled into anesthesia should not be reported in addition to the surgical or medical procedures requiring the anesthesia services if performed by the same physician. The following slide includes code descriptions for moderate conscious sedation services. These codes are found in the medicine section and not in the anesthesia section of CPT. CPT code 99143. This is for moderate sedation services other than those services described by code 00100 to 01999 provided by the same physician or other qualified healthcare professional performing the diagnostic or therapeutic service that the sedation supports, requiring the presence of an independent trained observer to assist in the monitoring of the patient's level of consciousness and physiological status, younger than 5 years of age for the first 30 minutes of inter-service time. CPT code 99144 is for ages 5 years or older for the first 30 minutes of inter-service time. And add-on code 99145 is for each additional 15 minutes of inter-service time. This code is listed separately in addition to the code for the primary service. So add-on code 99145 must be used in conjunction with 99143 and 99144. The listed CPT procedures notate intra-service time. What is included in intra-service time in order to best assign the correct procedure code? Intra-service time is defined by CPT as the time starting with the administration of the sedation agent or agents, requires continuous face-to-face attendance, and ends at the conclusion of personal contact by the physician providing the sedation. So to give an example of a moderate conscious sedation, if we have a 35-year-old patient that has moderate sedation services provided by the same physician that is performing the diagnostic or therapeutic service, and intra-service time is documented as a total of 75 minutes. How would this be coded? The answer to this would be 1 unit of 99144. This would account for the first 30 minutes of intra-service time. And then we would also bill add-on code 99145 times 3, which would account for the remaining 45 minutes. Additional moderate conscious sedation codes. We have CPT code 99148. This is for moderate sedation services, other than those services described by code 00100 to 01999, provided by a physician or a qualified healthcare professional other than the healthcare professional performing the diagnostic or therapeutic service. This is for younger than 5 years of age for the first 30 minutes of intra-service time. CPT code 99149 is for ages 5 years or older for the first 30 minutes of intra-service time. Add-on code 99150. This is for each additional 15 minutes of inter-service time. This should be listed separately in addition to the code for the primary service. So add-on code 99150 must be used in conjunction with either 99148 or 99149. There may be an unusual situation where the second physician that is not performing the diagnostic or therapeutic service provides moderate sedation in the facility setting for the procedures listed in CPT Appendix G. The second physician can then bill CPT codes 99148 to 99150 but cannot report these codes when the second physician performs these services on the same day as a medical or surgical service in the non-facility setting. Moderate sedation example number 2. A 5-year-old patient requires moderate sedation services, and this service is being provided by a physician other than the physician performing the diagnostic or therapeutic service. Inter-service time is documented as 120 minutes. How would this be coded? The answer to this would be 99148. This would account for 30 minutes of inter-service time. Add-on code 99150 times 6 would be billed for the remaining 90 minutes. Moderate conscious sedation does not require the presence of a qualified anesthesiology provider. For moderate sedation, either the provider performing the procedure or an independent observer such as an RN, an NP, or a PA may monitor the patient, and the level of sedation is not expected to induce depths of sedation that would impair the patient's own ability to maintain the integrity of his or her airway. What's the difference between moderate sedation and monitored anesthesia care? The essential difference between moderate sedation and monitored anesthesia care is the presence of a qualified anesthesia provider prepared to convert to general anesthesia or to rescue a patient from compromised function, such as airway or cardiovascular distress or failure. The next section on the way up the hierarchy is regional anesthesia. Regional anesthesia. This can be accomplished by nerve blocks to many areas of the body. The terminology for nerve blocks is often associated with the nervous system classification, anatomical location, approach, or reason for the procedure. Performance of regional anesthesia is often separately billable. All CPT code descriptors, section instructions, and payer guidelines for accurate billing information. The codes for regional anesthesia procedures are found in the surgery section in the nervous system subsection, not in the anesthesia section of CPT. If we take a look at the codes below, we see CPT code 64415. This is an injection of an anesthetic agent into the brachial plexus. The bilateral plexus can be approached in one of these 3 locations: the intrascalene, the supraclavicular, or the axillary. CPT code 64416 is an injection of an anesthetic agent into the brachial plexus, which is using a continuous infusion by catheter. The catheter is performed to achieve a longer-lasting nerve block effect than a normal single injection. An indwelling catheter is placed and positioned, and an infusion pump is connected to the catheter to supply a continuous flow of infused anesthetic agent at a set rate. CPT code 64417. This is for an injection of an anesthetic agent in the axillary nerve. CPT code 64418. This is an injection of an anesthetic agent in the suprascapular nerve. And for this code, this is done to relax the supraspinatus and the infraspinatus muscles and differentiate between brachial plexus mediated or C5 or C6 mediated pain. If we take a look at CPT code 64445, this is an injection of an anesthetic agent in the sciatic nerve. CPT code 64446 is an injection of an anesthetic agent into the sciatic nerve using a continuous infusion by catheter. This also includes catheter placement. CPT code 64447. This is an injection of an anesthetic agent into the femoral nerve. CPT 64448. This is an injection of an anesthetic agent into the femoral nerve using a continuous infusion by catheter. CPT code 64449. This is an injection of an anesthetic agent, lumbar plexus, posterior approach, using a continuous infusion by catheter. The lumbar plexus is formed from the nerve branches in the psoas major muscles, the ilioinguinal obturator, iliohypogastric, lateral femoral cutaneous, genitofemoral, and the femoral nerves. The patient is placed in the right lateral decubitus position, local anesthetic is given, then the needle is advanced toward the lumbar plexus, avoiding any transverse processes if the lumbar vertebrae until it is the proper position within the compartment of the psoas muscles, and stimulation of the plexus is seen by contraction of certain muscles. CPT code 64450 is an injection of an anesthetic agent for other peripheral nerve or branch. This CPT is used to report nerve blocks of other nerve branches not specifically listed in this section. CPT code 64520. This is an injection of an anesthetic agent, lumbar or thoracic, for the paravertebral sympathetic nerve. This lumbar or thoracic block provides anesthetic relief for pain in the torso, the pelvis, and the lower extremities. The next section we will be discussing is monitored anesthesia care. Monitored anesthesia care is a physician service that is clearly distinct from moderate sedation due to the presence of a qualified anesthesia provider prepared to convert to general anesthesia or to rescue a patient from compromised functions such as airway or cardiovascular distress or failure. The expectations and qualifications of the provider who must be able to utilize all anesthesia resources to support life and to provide patient comfort and safety during a diagnostic or therapeutic procedure. Post-procedure responsibilities. Monitored anesthesia care post-procedure responsibilities go beyond the expectations of practitioners providing moderate sedation, including assuring a return to full consciousness, relief of pain, management of adverse physiological responses or side effects from medications administered during the procedure, as well as a diagnosis and treatment of coexisting medical problems. Monitored anesthesia care is reported using codes from the anesthesia section of CPT with modifier QS. We will take a look at modifier slide later on in the presentation. Monitored anesthesia care. The presence of an underlying condition alone may not be sufficient evidence that monitored anesthesia care is necessary. The medical conditions must be significant enough to impact on the need to provide monitored anesthesia care. Examples may be if a patient is on certain medications or if they are symptomatic. The presence of a stable, treated condition of itself is not necessarily sufficient. Please refer to local carrier policies determinations to identify what diagnosis may support medical necessity. Next, let's take a look at general anesthesia. General anesthesia. This is a medically induced coma and loss of protective reflexes resulting from the administration of one or more general anesthetic agents. Purposes of general anesthesia. Analgesia, which is loss of response to pain. Amnesia, which is loss of memory. Immobility, which is loss of motor reflexes and skeletal muscle relaxation. And unconsciousness, which is loss of consciousness. General anesthesia requires higher levels of care, monitoring, and available resources to protect the patient due to the level of suppression of physiological function. Providers of general anesthesia require specific credentials and training in accordance with federal and state statutes, as well as other governing bodies such as Joint Commission, medical boards, and healthcare facility organizational policies. General anesthesia CPT codes. Anesthesia CPT codes are located in the anesthesia section in the second section of CPT and are organized primarily by anatomical, location, and also categorized by procedure and other descriptors. The following is a general organization of anesthesia codes. If we take a look at the head area, we'd be looking at CPT code range 00100 to 00222. If we were looking at procedures of the neck, we would indicate and reference code 00300 to 00352. If we're looking at the thorax, including the chest wall and shoulder girdle, we'd look at CPT code 00400 to 00474. If we're looking at the intrathoracic area, we would reference 00500 to 00580. The spine and spinal cord, we'd look at 00600 to 00670. The upper abdomen area would be referenced over to 00700 to 00797. The lower abdomen area would go to 00800 to 00882. Would code 0902 to 00952. The pelvis, except the hip, would be 01112 to 01190. The upper leg area, with the exception of the knee, would be 01200 to 01274. The knee and popliteal area would be 01320 to 01444. The lower leg, which includes below the knee, ankle, and foot, is 01462 to 01522. The shoulder and axilla area would be 01610 to 01682. The upper arm and elbow area would be 01710 to 01782. The forearm, wrist, and hand would be 01810 to 01860. The radiological procedures would be referenced over at 01916 to 01936. Burn excisions or debridements would be 01951 to 01953. Obstetric would be referenced over to 01958 to 01969. And there may be other procedures that would have to be referenced to 01990 to 01999. Let's take a look at the general anesthesia coding process. First, we would want to locate the code in the CPT index. We can do this by looking at the anatomical location, the procedure itself, the approach that was taken, and other specific code descriptions such as age. Then we would want to append appropriate modifiers and qualifying circumstances. Last, we would want to code any procedures that could be separately reportable. General anesthesia inclusions. Services included in anesthesia codes would include a preoperative visit, postoperative visits, anesthesia during the procedure, administration of fluids and blood, and usual monitoring. General anesthesia payment. There are multiple factors that formulate reimbursement for anesthesia services, distinguishing anesthesia from other medical services and how they are coded, reported, and reimbursed. Before we look at the formula, there are some basic guidelines to be noted. Only one anesthesia code is selected for multiple procedures, but there are exceptions to this rule. An exception of this would be anesthesia add-on codes. For example, add-on code 01968 is for anesthesia for a cesarean delivery following neuraxial analgesia and anesthesia. There is an exception with obstetrical add-on codes. Medicare requires that when using obstetrical add-on codes, that the anesthesia time be reported separately with each of the primary add-on codes based on the amount of time associated with each code. In these cases, such as the example on the slide, both the base units and the time units for the primary and add-on obstetrical anesthesia codes would be recognized. Report the most extensive or most complex and use a total anesthesia time for all procedures. An example of this would be if a patient had two procedures and the anesthesia codes were 00147 for an iridectomy that lasted an hour and 00145 for a vitreoretinal surgery that took 2 hours. This would be billed as 00145 for the vitreoretinal surgery, as it has a base unit of 6, while 00147 for the iridectomy only has the base unit of 4. The total amount of anesthesia time that we would bill with this example would be 3 hours, as the iridectomy took 1 hour and the vitreoretinal surgery took 2. So as we can see, we took the base unit of the highest procedure and the time units for the total time of both procedures. General anesthesia repeated procedures. Repeat procedures are serviced by the same physician. This is indicated by using modifier 76. This is when the patient returns the same day for the same or related procedure. A repeat procedure by another physician would be indicated with the use of modifier 77. This would be when the patient goes back to surgery on the same day for the same or related procedure by a different physician. Some examples of these situations would be if a patient had a procedure performed for an upper gastrointestinal endoscopy and the physician bills for the 00740 code. Then the patient is brought back to surgery suite to undergo a lower intestinal endoscopy, and the same physician performs the anesthesia and bills 00810. The second procedure, 00810, would be billed after the appropriate anesthesia modifiers with a 76 modifier, as the patient had a repeated similar procedure on the same day by the same physician. Now, if a different physician were to be performing the procedure, then they would have billed the second procedure, the 00810, for the lower intestinal endoscopy with a 77 modifier instead of the 76 modifier. General anesthesia reimbursement. Components of anesthesia reimbursement. We have base values, which are relative values or RVUs. A listing of these can be found at the website at CMS. Time units, which are indicated in blocks of 15 minutes. Physical status modifiers, and qualifying circumstances. General anesthesia payment. The formula to calculate the allowed amount for anesthesia for Medicare is base units plus time in units times the conversion factor, which equals our anesthesia fee amount. Commercial payers may include other factors such as physical status modifiers. Thus, the formula would be base units plus time in units plus modifying units times the conversion factor, which would give us our anesthesia fee amount for commercial payers. General anesthesia time. Anesthesia time begins when the patient is prepared, ends when personal attendance is not required, and time units are 15-minute increments. So our example, if for 2 hours of anesthesia time, would equal 120 minutes divided by 15, which gives us 8 time units. So for anesthesia time, one time unit of 15 minutes will be allowable from the time the physician begins to prepare the patient for induction and ending when the patient is placed under postoperative supervision and the physician is no longer in personal attendance. General anesthesia time. Never round time increments to the next whole number. Only round to the next tenth of a number. So our example is if the anesthesia time was a total of 127 minutes, we would divide this by 15, which would bring us to 8.47. We would round to the next tenth, which would be 8.5. A second example would be 35 minutes of anesthesia time. We would again divide this by 15. This would bring us to 2.33, which we would round down to 2.3. The total units found from the above equation will be added to the base units assigned for the procedure. Total units are then multiplied by the conversion factor. Anesthesia time and total minutes must be entered into item 24G of the CMS 1500 claim form or electronic equivalent. General and base units. What is a base unit? Units that are assigned to reflect the difficulty of the anesthesia service. This includes usual preoperative and postoperative care and evaluation. This is used to determine a portion of the reimbursement amount of the anesthesia procedure. General anesthesia conversion factor. Anesthesia conversion factors for each calendar year are listed by payment modality and are effective for the date of service provided. Participating physician anesthesia conversion factors listed first. Then, non-participating physician anesthesia conversion factors are listed second, and non-medically directed conversion factors are listed in the third column. Anesthesia conversion factors can be found at CMS at the listed address on the slide. The non-physician conversion factor is computed at 95% of the participating physician conversion factor. The limitation in the status requires that the qualified non-physician anesthetist services not exceed the conversion factor for physician anesthesia services. General anesthesia and physical status modifiers. P1 indicates a normal healthy patient. P2 indicates a mild systemic disease. P3 is for a severe systemic disease. P4 is a constant threat to patient's life. P5, not expected to survive without surgery. And a P6, which is declared brain dead patient. Looking at coding guidelines for Medicare, Medicare does not recognize physical status P modifiers. Looking at CPT assistant information, they identify a level of anesthesia and are reported in conjunction with anesthesia service codes when appropriate. Physical status modifiers are represented by the initial letter P, followed by the appropriate single digit from 1 to 6. These 6 levels are included in the anesthesia guidelines of the CPT codebook to distinguish among various levels of complexity of the anesthesia service provided. Other modifiers located in Appendix A of the CPT codebook may also be appropriate. These 6 levels are consistent with the American Society of Anesthesiologists ranking of patient physical status, which can also be found at the ASA website listed here on the slide. General anesthesia, separately billable services and qualifying circumstances. Qualifying circumstances qualify for additional units to be utilized in anesthesia total unit calculation. Add-on code 99100 for under 1/70. When referencing this code in CPT, there is a note underneath to reference the following CPT codes when billing for a patient that is under the age of 1 year old. CPT codes 00326, 00561, 00834, and 00836 are all codes specific to patients under the age of 1 year old. When looking at these codes, they do instruct us that add-on code 99100 cannot be separately billed. Add-on code 99160 indicates complicated by hypothermia, which is an additional 5 units. Add-on code 99135, complicated by controlled hypertension, and that's an additional 5 units. Add-on code 99140, complicated by emergency, and is an additional 2 units. Per CPT, an emergency is defined as existing when delay in treatment of the patient would lead to a significant increase in the threat to life or body part. Qualifying circumstances that significantly the nature of the anesthesia service provided. And codes that were just referenced are all add-on codes and would be billed in addition to the qualifying anesthesia procedure. Also note that more than one qualifying circumstance may be selected when appropriate. General anesthesia, anesthesia payment examples. For a colonoscopy, a patient with obesity, DM, and hypertension has a colonoscopy under general anesthesia. The procedure takes 30 minutes and anesthesia is provided by an anesthesiologist. CPT code 00810 for anesthesia for lower intestinal endoscopic procedures. Endoscope introduced distal to duodenum. We would have a base unit of 5, time unit of 2, and an ASA physical status modifier of 3. For a Medicare patient, the physical status modifier would not be applicable. So there'd be no qualifying circumstances in this example. Anesthesia payment examples. For Medicare, we would have that base value of 5. For the 30 minutes, we would divide that by 15 to bring us to 2 time units. If we add the 5 and 2 together, we would get a total units of 7 times the conversion factor, which would give us a reimbursement. If we take a look at a commercial payer, we would again have that base value of 5. We would take the 30 minutes, divide it by 15 to come to the same 2 time units. And then we would also have a P3 status modifier giving us 1 additional unit. The total units would times the conversion factor, which would give us our commercial reimbursement. General anesthesia modifiers. HCPCS level 2, we have AA, which indicates that this was performed by an anesthesiologist. AD, which is medically supervised by a physician. GC, these services have been performed by a resident under the direction of a teaching physician. QK, which is medically directing 2 to 4 concurrent procedures, which is cases happening at the same time. Which is monitored anesthesia. QX, CRNA service, medically directed. QY, medically directing CRNA single case. QZ, it's a CRNA without medical direction. General anesthesia modifiers. An AD would be medical supervision of more than 4 concurrent procedures. G8, monitored anesthesia care for a complex procedure. G9, monitored anesthesia care for a patient with severe cardiopulmonary condition. 53, it's a discontinued procedure used if surgeon discontinues the procedure. And modifier 59, which is a distinct procedural service or our new X modifiers, which were started in January 1st, 2015. XE is for a separate encounter. XS is separate site. XP is for a separate practitioner. And an XU is an unusual, non-overlapping service. General anesthesia during surgery, then an epidural is placed for post-op pain management, may qualify for an additional service that could need a 59 or an X modifier. Please also utilize NCCI bundling edits in regards to billable services with anesthesia. Qualified anesthesia providers. The following are authorized medical providers of anesthesia services as long as properly trained and credentialed and operating within their scope of practice and supervised, directed when applicable under guidelines. If we take a look on the screen here, we have medical provider. This could be an MD, a DO, or a DPM. We have a resident physician, a CRNA, which is a certified registered nurse anesthetist, and a non-physician anesthetist, which could be an NP or a PA. Concurrent medical direction. Concurrency is defined with regard to the maximum number of procedures that the physician is medically directing within the context of a single procedure and whether these other procedures overlap each other. This is not dependent on each case involving a Medicare patient. An example of this is if an anesthesiologist directs 3 concurrent procedures, 2 being Medicare patients and 1 non-Medicare. This would still represent 3 concurrent cases, as it does not matter if the patients are Medicare or non-Medicare. Medicare policy for medical direction. If an anesthesiologist is medically directing more than 4 qualified non-physician anesthetists, the Medicare regulations indicate that the service must be billed as medically supervised as opposed to medically directed anesthesia services. When the anesthesiologist is involved in furnishing more than 4 procedures concurrently or is performing other services while directing the concurrent procedure, the anesthesiologist bills the AD, HCPCS, MODIFIER, and payment is based on 3 base units per procedure. Additional time unit can be recognized if the physician can document they were present at induction. A qualified non-physician anesthetist bills with the QX HCPCS modifier. Medicare payment is 50% of the Medicare allowable amount for the procedure. Medicare policy for medical direction. The QK modifier is for the medical direction of 2 to 4 concurrent procedures. Documentation must indicate a pre-anesthetic exam and evaluation, prescribing an anesthesia plan, personally providing any demanding parts, a qualified individual, monitor the course at frequent intervals, remain present and available, and provide post-operative care. General anesthesia concurrent medical direction examples. We take a look at the chart on the slide. We have different columns indicating procedures A through D, the duration of each procedure, and the number of concurrently medically directed procedures at a given time. So procedures A through D are medically directed procedures involving a qualified non-physician anesthetist. The start and end times in the duration column indicate the anesthesia time that is being counted for each procedure. So if we take a look at procedure A, our duration is from 8:10 a.m. to 8:45 a.m. During this time, only 1 medically directed. Procedure B is from 8:30 a.m. to 9:15 a.m. and we have 3 concurrent medically directed procedures during this time happening. Procedure C is from 9 a.m. to noon, And there are also 3 concurrent medically directed procedures as well. Procedure B would be from 9:10 a.m. to 9:55. Again, 3 concurrent medically directed on at that time. Caution with medical direction. A physician who is concurrently directing the administration of anesthesia to no more than 4 surgical patients cannot ordinarily be involved in furnishing additional services to other patients with the following exceptions: addressing an emergency of short duration in the immediate area, administering an epidural or caudal anesthetic to ease labor pain, periodic but not continuous monitoring of an obstetrical patient. They can receive patients entering the operating suite for the next surgery, check and discharge patients in the recovery room, and handle scheduling matters. The above procedures will not affect Medicare payment if they are performed. It is important to note that if the physician leaves the immediate area of the operating suite for other than short durations, or uses extensive time for an emergency case, or is otherwise not available to the immediate needs of surgical patients, then the physician's services to the surgical patient are supervisory in nature and are therefore not reimbursable by Medicare. General anesthesia. 1 procedure performed, but 2 anesthesiologists or 2 qualified non-physician anesthetists are present. This scenario can happen if the first anesthesiologist or the qualified non-physician anesthetist has to leave the patient to start another anesthesia procedure, and the procedure is taken over by a second anesthesiologist or second qualified non-physician anesthetist. In this case scenario, how would we bill this? The anesthesiologist or qualified non-physician anesthetist that spent the most amount of time with the patient should receive credit for this service. So, if our first anesthesiologist or qualified non-physician anesthetist spent 15 minutes with the surgical patient, but then had to leave and a second anesthesiologist or qualified non-physician anesthetic procedure and spent a total of 45 minutes with the patient, the second anesthesiologist or qualified non-physician anesthetist would then submit the claim with 60 minutes for the entire period of the procedure. Unusual circumstances. It may be medically necessary for both the qualified non-physician anesthetist and the anesthesiologist to be completely and fully involved during the procedure. Full payment for the services of each provider is allowed. The physician must use the AA Hicks modifier. The qualified non-physician anesthetist must use the QZ Hicks modifier. Documentation must be submitted by each provider to support payment of the full fee. General anesthesia, separately billable services. You could have a central venous catheter or CVP. This would be coded to 36555 or 36556. This includes the monitoring and the quick administration. We have an arterial line insertion, which is a 36620 and a 36625. And this is based on the technique used. GONS, which is a 93503. Included if done through the CVP, and a separate vessels code for both. Always refer to resources such as payer guidelines and policy as well as CCI edits when billing for separate services. General anesthesia sample documentation. Key elements needed in the documentation would be patient identifier, procedures, diagnosis, provider credentials, anesthesia type, time documentation, monitoring documentation, and ASA physical status. Let's take a look at some rules regarding teaching physicians. Medicare pays an unreduced fee schedule payment if a teaching anesthesiologist is involved in a single procedure with one resident. Documentation must state that the teaching physician was present during all critical or key components of the procedure. The teaching physician's physical presence during only the preoperative and postoperative visits with the beneficiary is not sufficient to receive payment. When the teaching physician is involved in two concurrent anesthesia cases with residents, the teaching anesthesiologist bills the usual base units and anesthesia time for the amount of time he is present with the resident. Anesthesiologists must use the AA-HCPCS modifier. Documentation must support the fee and be available upon request. Anesthesiologists can bill base units if they are present with the resident throughout the pre- and post-operative anesthesia care. Teaching physicians. If different teaching anesthesiologists are present with the resident during the key or critical periods of resident care, the National Provider Identifier, or NPI, of the teaching anesthesiologist who must be indicated in the correct on either the or the form. The teaching anesthesiologist should use the AA-HCPCS modifier and the GC certification HCPCS modifier. The anesthesia modifier, or the payment modifier, should be billed first, followed by the GC modifier. Example number 1. If the teaching physician is involved in a single anesthesia procedure with one resident, then the teaching physician should bill his services with the AA and GC modifier. Example 2. If the teaching physician is involved in two concurrent anesthesia cases with two residents, the teaching anesthesiologist may bill the usual base units and anesthesia time for the amount of time he is present with residents. These services should also be billed with the AA and GC modifiers. Teaching qualified non-physician anesthetists. These can be paid under Medicare if they are in medical direction of a physician. They must be continuously present and supervising a single case involving a student nurse anesthetist. In a single case scenario, if the teaching qualified non-physician anesthetist is supervising a case performed by a student nurse anesthetist and is present with the student throughout the case, payment can be made at the regular fee schedule rate. A qualified non-physician anesthetist should report the QZ-HCPCS modifier. The use of the QZ modifier then indicates that the qualified non-physician anesthetist is not under the medical direction by an anesthesiologist during the time of the procedure. Here are some additional resources to reference when coding for anesthesia. It is very important when performing any type of anesthesia coding to utilize any and all of these resources to ensure that you are coding correctly for all the services performed. Thank you for attending today's webinar, Introduction to Anesthesia Coding. My name is Michelle Corbish. Please do not forget to obtain your CEU certificate, and also please complete the post-test.